Hi, I'm Danny Steinberg from MUSC in Charleston, South Carolina. I'm here with the one and only Gregg Stone from Cardiovascular Research Foundation, New York. How are you doing?
Good, how are you?
Welcome to CRT 2014.
Great to be here.
So today we're going to talk a little bit about left main coronary vascularization, something I know you've published a fair amount on in the past and thought a lot about. And so, you know, as a background for someone like me who came out in 2008, really, left main has kind of crept from being taboo during my fellowship to something we're kind of thinking about. So can you tell us a little bit about that?
Sure. Well, you know, we've got a long history in the field of interventional cardiology of trying to treat unprotected left main disease. And we started really with Jeff Hartzler in the early days of balloon angioplasty, and we had a high rate of acute procedural complications, sudden death there, and actually restenosis actually often presented as sudden death in left main. So that kind of went out the wayside. And bare metal stents improved the situation somewhat, but mainly back then we were primarily doing the patients who the surgeons turned down. So left main PCI didn't really look that good. There weren't really randomized trials. So everybody got very excited with the fact that drug-eluting stents might really eliminate, especially modern drug-eluting stents, really eliminate both the risk of stent thrombosis, because we've got a large vessel with a short lesion for the most part, and two, restenosis. And if we could eliminate restenosis in the left main, or at least markedly reduce it, then maybe we could be competitive with bypass surgery.
And so how close do you think we are?
Well, I think we've gotten closer. We're not quite there yet, and I think there have now been 4 or 5 decent randomized trials of left main DES versus bypass surgery, by far the best being the Syntax trial, and that wasn't actually a dedicated trial. That was actually left main or triple vessel disease randomized to Taxus paclitaxel-eluting stents versus bypass surgery, and of 1,700 patients, 705 of them had left main disease, so it's the biggest randomized trial to date. And overall, they enrolled in that trial some very simple patients with left main disease, and then very complex patients with double, triple vessel disease. Some patients getting, more than 100 millimeters of stent, and 7, 8, 9 stents, so some very complex patients. And overall, there wasn't statistically significant differences between the left main cohort and the who had PCI and CABG in terms of the outcomes that mattered, really, death, myocardial infarction, and stroke. But there really was a gradient of outcomes in that the lower risk, or maybe the intermediate anatomically risk patients, according to the so-called Syntax score, really did pretty well with PCI, even with Taxus stents, at least as good, maybe even a little better than surgery in some measures, certainly less stroke. Whereas the most complex patients clearly did better with bypass surgery. But it's got to be emphasized, now I'm talking about subgroups of subgroups, because even the left main group is a subgroup, so we can't make any definitive statements from Syntax about left main PCI. But I think it got us as a subspecialty out of so-called stent jail, where before left main PCI was class 3 in most of the guidelines, and now it's class 2B and rarely class 2A for really simple cases.
Yeah, so what of location within the left main itself, or the complexity of the PCI?
Some studies, many studies have actually shown, if you look at the 3 locations, either ostial, mid-shaft, or distal bifurcation, it seems intuitively obvious that ostial and mid-shaft would be pretty easy. Short lesion, large vessel without the bifurcation issues, where the distal bifurcation might be more complex. And I think most studies have suggested that holds true. The long-term outcomes with drug-eluting stents and ostial and mid-shaft PCI seem very, very favorable. High procedural success rates, low recurrence rates. The complex distal bifurcations are another animal. Although in Syntax, interestingly, the MACE rates weren't all that different between the distal bifurcation and non-bifurcation lesions, but that's really the only trial to have shown that. So I think most interventionalists have a tough distal bifurcation, especially if you have to stent both limbs, not just do a simple crossover technique. That's much more complex for PCI.
So 30,000-foot view, next 12 to 24 months. What do you think is going to change as we approach this?
Well, I can't tell you too much in the next 12 to 24 months, but I think in the next 36 to 48 months, a fair amount will change. And that's because, there are now a couple randomized trials that are going on that are looking at current generation drug-eluting stents versus PCI, and not in an all-comers population, but in more appropriate types of patients for PCI. Some of those patients that were being done in Syntax were just outrageous, were ridiculous, not the kind that you or I would almost ever do, but they kind of got forced into this trial. So the Excel trial is the largest trial of its kind, with 2,600 randomized patients being randomized to the fluoropolymer-coated everolimus-eluting stent, the Xion stent family, versus bypass surgery. And that's powered to show, at a median follow-up of 3 years, the outcomes of death, MI, or stroke between the two groups. And I think those are the major endpoints. Revascularization, maybe a little bit more or less. Atrial fibrillation, maybe a little more or less. Renal failure, a little bit more or less. But if death, MI, and stroke are pretty comparable between the two groups, then I think both therapies will be considered reasonable approaches, in which case many patients will opt for PCI because of its lesser invasive nature.
And you think if death, MI, and stroke, and primarily, obviously, revascularization is another beast to itself, but yeah, death, MI, and stroke are favorable, or at least not inferior, we should say, then perhaps potentially an indication shift again from 2B, 2A?
Then then I'd hope it go to Class 1. I mean, if we really have similar 3-year plus outcomes for death, MI, and stroke, then to me that's a Class 1 indication, with the concept being that medical therapy, when we tried to treat at least 30 years ago left main patients with medical therapy, even though it's not what it is today, the mortality rates were tremendously sky high. So by implication, and there have been actually studies written on this, if CABG markedly improved those outcomes. So if PCI is really not inferior, then I think it should be Class 1 as well.
Well, thank you. I want to thank you for joining us today.
Great, my pleasure.